What I would like to give you in this presentation is trying to make sure that you have all the technical background about the technology, how it works, and why it's actually unique and different from what else is in the market at the moment. So starting from the target group, we all know that presbyopia is a huge market, and for us it's essential to be able to add something in the market that could add value to the patients and the clinicians as well. And when we look at the presbyopia world, this is one of the graphs that we got from the ECRS report. We all know that there is a huge gap, which is called the presbyopia gap, and it's the gap that is related to emmetropic presbyopes. So still today, only 1% of patients treated with laser are actually emmetropic presbyope. So with Allotex, we really want to try to fill that gap. And when the clinical trial was made in 2019, Allotex was originally thought purely for emmetropic presbyope. But however, we have been able now to kind of broaden that patient groups and being able to offer this solution to many other people in the market. So today we will be presenting you 3 different groups. Of course, there will be the big one, the first one, which is the pure emmetropic presbyopes. But we have also been able to offer Allotex to other two groups. One is what Harry was just saying before. So people like Harry who had like LASIK 20 years ago and they become presbyopes and they want to have a solution for the presbyopia. And the other group, which is also at the moment one of the most prominent for us, like is where we have most of our commercial cases so far, is for all these people that they come to your clinic today, they already have a kind of the refractive error for distance within a range that I'll show you in a moment, and you can offer Allotex in combination with LASIK for those patients. What you can see on this slide is actually our guidelines as of today. We all know that this is a new technology, and as all the new technology, they develop with time. So we have solid results in what is written on those slides, but this doesn't mean that in the near future we might also be able to broaden those numbers a little bit. But just as of today, what we can confidently say is that you can easily use Allotex on emmetropic presbyopes that have a cylinder within 0.75 diopters. They don't have much difference between the manifest and the cycloplegic refraction, and also they don't have already high order aberration in their corneas, and I'll explain you why later. Again, same thing for post-refractive surgery, same thing as the emmetropic. Finally, for the last group, which is the combination one, today we have been treating patients that are in a range between -3 diopters of myopia to +2 diopters of hyperopia, with a cylinder which is roughly to -2. So it's still already quite a big group, but we hope that with time we can even go a little bit further. Let's deep dive a little bit more into the tissue itself, the technology itself. So as Michael said before, we actually get the corneas from an eye bank in the States, which is Vision Gift. They are able to provide us with corneas that are e-beam sterilized, and therefore there are no active cells into those corneas, and they are stable at room temperature for 2 years. And what we do is we get those corneas and we process in the tissue facility that we showed you in the previous slide. Therefore, this is very important for us because what we can offer you is then a product that is stable at room temperature. You can easily have it on your shelf and use it when it's ready. And has a very easy logistics behind it in terms of management. The good thing about the presbyopia inlay is that differently from what you do with CARES, that you have to do, some heavy calculation and pre-op planning. For us, for the presbyopia tissue, you will see today, we will make you practicing with the tissue, but the tissue is extremely tiny. So the tissue is a 2.5 millimeter diameter and only 20 microns in thickness. And that's the reason why we can have Allotex today and we could not have Allotex 50 years ago. Because although you have, at the end of the day, the end result will be a very standard package, more or less like a contact lens, at the end of the day, for getting to that place, we had to have that huge engineering background. We have to be able to shape human tissue at a resolution which is below the 20 microns. So this was not possible 20 years ago, 30 years ago. And that's the reason why Allotex is on the market today. This is ready-to-use tissue that you can just open and use it. And this is what we will be doing it today. At the moment, our tissue has 1 year of shelf life, but just because we didn't have time, we have not completed yet the shelf life test for 2 years, so we didn't have tissue left there for 2 years yet. Once that test will be completed, we'll be able to also increase the shelf life to 2 years, which is the shelf life that we normally get from Vision Gift. So as I was saying, like Allotex is Allotex because as all what we do is we know how to process the tissue, and the technology behind is quite complex. We really wanted to give you the key steps that our technicians, our tissue processing technician, do every day in the lab. So we get the corneas, as you can see there, from Vision Gift. We refine the buttons and we cryo-cut them. Once we have all the cryo-cutted buttons, the buttons will go into the excimer laser, the industrial one, and the industrial excimer laser has 3 OCT systems there that guide the laser shaping. The final product is the tissue itself, and what we do is we send them to e-beam sterilize again, so to make sure that the product that you get has the characteristic that I showed you before. In terms of vision, in terms of how the technology works, as we were discussing before, the technology of Allotex is very similar to an EDOF lens. So on the right side, you will see what you normally have for monovision. We all know monovision. And what we will be getting with Allotex is a better outcome in terms of vision, because while the dominant eye will still be perfect for distance, the non-dominant eye will have the Allotex inlay. We will get, of course, there will be a slight loss in the distance vision, but it's much broader range compared to monovision. One thing that it's always quite important to understand is we always get a question about how many diopters do you add, how many diopters can you actually provide. The reality is that Allotex tissue is human cornea. Being human cornea, when we insert human cornea within human cornea, we are just inserting a spacer, because the refractive index of the piece of tissue that you will be adding is exactly the same refractive index of the cornea. So it doesn't act as a lens, it acts as a spacer. What we do is that by reshaping the cornea, we are able to create spherical aberrations. And those spherical aberrations are actually able to give us the defocus curve that we need. And the focus curve are quite nice because we can get to roughly 2.75 diopters of defocus. Before we move to the clinical outcomes, this is a very quick slide to see how the procedure will be. Again, those are just marketing material that we normally use for communicating with the patient, not with the surgeon. But easily, what we do is, although the technology behind is quite complex, the usage is very easy, because it's just standard flap. The inlay has been designed for a flap thickness of 110, 120 microns. Then we add the tissue and we close it. Of course, if we do it in combination with LASIK, before adding the tissue, there will be the ablation. So moving to the clinical outcomes, as Michael was saying before, we have just completed the 4-year follow-up collection of the data. The clinical trial started in 2019. Overall is 101 patients, and we have data at 6 months, 12 months, and now we have also the 4-year follow-up. Corneal inlays before that were synthetic. We all know that within the first 2 years started to get, we all see the quite important inflammation and days in the corneas. And that's actually the first question we always get asked when we present Allotex. And this is the reason why we're very happy as of today, because although the previous inlay were developing severe haze within the first 2 years, now that we have follow-up data at 4 years, some of them actually now even 5 years, we can easily say that there is no haze in those patients, which is, first of all, very, very important for us for the safety of the tissue. Technology works is that once we insert the Allotex inlay, what will happen is that the epithelium will make its magic. So the epithelium will remodel the shape, and that's the reason why when we will be talking about how the refraction will change in the first weeks, actually we will have a myopic shift first, and then the epithelium will do its magic and it will get better over the first weeks. In terms of vision, in terms of clinical trials, we were able to achieve all the safety and efficacy endpoints. And I will show you some graphs on the data itself, but generally we are able to gain 4 to 5 lines of reading vision for the patient. And this explains how we change the uncorrected visual acuity over the months. Again, those are all the data that we collected for the clinical trial. On the x-axis, there are the months. It goes from 0 to the 4 years. And on the y-axis, we have added all the different distances. In blue, you will find distance vision. The bottom line is the Allotex eye. The top line, the blue line, is the binocular distance vision. Again, same thing for the near, the intermediate. So the black line is the intermediate. We have both eyes on the bottom and treated eye on the top. And then the green lines are the near vision, both eyes and treated eye. This graph is very important for us to show you how the patient will behave immediately after implantation. So as you can see, generally what we can say is that at steady state, the patient will lose roughly 1 line of distance vision in the Allotex eye. There is no compromise on the binocular vision, of course. Binocular vision remains perfectly flat. And by losing that 1 line of distance vision in the Allotex eye, they will actually gain, on an average, 2 lines of vision in the intermediate and 4 lines of vision in the near. So that's what happens. And as you can see here, this is the epithelium remodeling effect that I was telling before. So immediately after implantation, normally the eye, what we see is you get like minus 1.75, 1.5 diopters of myopia. And then over the first weeks, this goes to the steady state, which is roughly minus 0.5 diopters of myopia. And this what happened. This what means that immediately after implantation, they might lose 3 to 4 lines of distance vision on the eye that will get to 1 line after a few weeks. This is another slide which is quite important for us, because what you can see here is on the bottom you will have the best corrected distance vision, and on the top you will have the near vision corrected for distance. And as you can see here, the corrected vision, the near vision corrected for distance is not 0. So this is important, because if it was pure monovision, it would have been 0. Again, this is how the refraction will behave in the first months. So there will be a shift in there will be a myopic shift that will be back in the first, let's say, few weeks. Normally, we all have seen the patients at 3 months, and at 3 months they already were at the result that then they was stable for the rest of the years. Again, those are how we are collecting the data. These are interim analysis, but just to show you very quickly that the cornea, as we were saying before, is completely clear. We can only see some traces sometimes in some patients. For us, this slide is quite important, because what we have seen is that working in this age group, as you can all imagine, we saw quite a immediate drop after the LASIK, of course, as a normal LASIK. Then it got stable, but at 4 years, we can start to see some kind of drop in the tear film back at time, which is normal because those people are just aging. So this slide is just to say that you will see in our recommendation, in our pre-op evaluation, post-op evaluation, we always talk about dry eye as well, because we think it's quite an important part of the procedure itself, to making sure that we can optimize the management of the tear film before and after the surgery. We have also starting to look at lens opacification on those patients. Again, those patients are aging, but we have to say that although they were quite young patients, so we didn't find any kind of cataract in them, a couple of opacifications, but nothing special. The last 2 slides that I really wanted to show is just because what makes Allotex also unique, it's the fact that it's an additive technology compared to a subtractive technology. And this is quite important for the clinician, but also for the patient. We are always seeing every day the fact that patients, they feel much more safer when you can say to them that this is actually something that you are adding to their cornea. You are not removing anything from their cornea. And if they really don't adapt to the vision, or if there really would have been something very peculiar for that patients, you can easily lift the flap, remove the tissue, close the flap, and the patient will go back to baseline. And this is something that we will be showing you later as well, because we have got a couple of cases during the clinical trial where we removed the inlay, and we used those cases for actually measuring how they got back to baseline. And results are pretty remarkable, because they got back to baseline within the first 3 months after explantation. So the reversibility for us is quite an important topic, which it's important for you as a surgeon, but I think is something that is easily transferable also to the end patient. And then we will be guiding you also all about what is Allotex in terms of benefit for the clinic, not only in terms of clinical side, but also commercially. And I think when we talk about technology like this, the beauty of these technologies is that they don't require any kind of big investments in capital equipment or something like this. We all work, I think everyone in this room has already a femto laser and excimer laser, so we don't need to do any kind of big investments for starting with Allotex. Again, for us, optimizing the logistics behind having a tissue that is ready to use, sterilized, you can have it in your clinic, you can easily use it on the day that you need. It's essential, because this doesn't add any kind of complication related to how we normally work with corneas and other stuff. And finally, also, we really think that by being able to serve more patients, this might be also a driver for increasing the quality and the profitability and the kind of standing of the clinic itself. So we really think that Allotex can be a nice addition to your techniques that you normally are offered today, to making sure that there will be every day a bigger pool of patients that you can serve.